About the job. What are different contents that are the anesthesia contains?
Anesthetics have they have a multitude of contents actually, and they've changed a lot over the years. Anesthetics originally started with chloroform, and it was all a liquid that was dropped into a cloth and held over your nose or mouth until you essentially became unconscious. And it was hard to um, determine death, and actually it resulted in a lot of deaths because there was no way really to determine deaths. If the person wasn't healthy, they died before they woke back up. So they've really evolved during the years, and now an anesthetic is a combination of an analgesic, an amnestic, usually muscle relaxant, um, those three main components. So nowadays we put you to sleep with one agent, either something called propofol, pentothal, brevitol, one of the agents, and we actually keep you asleep with an inhalation agent that you actually breathe. And it's a distant chemical relation to chloroform, but it's a much more palatable, doesn't have that nausea, vomiting, less recall, it's just much more well tolerated. Um, those are the main components. And then if you have a case that is like an intra-abdominal case or a muscular case or skeletal case where you need muscle relaxation, we actually give you paralytics that are like the old-fashioned curare that the Amazon Indians used to use. And they actually paralyze you so that if your anesthetist or anesthesiologist didn't take over breathing for you, you would essentially be apneic and die. So after we put you to sleep, we then proceed to paralyze you and take over breathing for you, then to keep you alive and give you some pain medicine, some analgesia while you're asleep, one of the many different ones, so that you wake up comfortable when we finish the procedure. So we've come a long way from the old-fashioned inhalation that you just held over your nose and got sick as a dog when you woke up, to modern anesthetics where the incidence of nausea is pretty well gone and you wake up pretty comfortable.
Um, so you kind of touched on it, but what are the different types of anesthetics?
There's a lot of different types. There's a general anesthetic, and that's probably the one that most people are really familiar with. That's used for a lot of abdominal surgeries, facial surgeries, and that's what people usually are most comfortable with. They just want to go to sleep and not remember anything. So that's the one where we start intravenous and we give you the medicine to drift you off to sleep, and then take over your breathing and titrate in the amnestics so that you have no recall, and that's the one type. Then there's also neuraxial anesthetics, and those are the ones where we block the nerve tracts in your body. Like going to the dentist, they put some lidocaine in your gums and the gingiva and they numb your mouth. Well, that's a neuraxial anesthesia. And the other types, of course, are epidurals, which everyone knows for labor and delivery, and spinal anesthetics, which we also can use for C-sections and or a lot of times lower body orthopedic surgeries. Those work real well. And then one of the more common modern types of anesthetics we've developed is what we call a MAC or a twilight or a sedative type of anesthetic, where we actually sedate you pretty heavily, but we don't have to take over breathing for you, and then we use a local anesthetic and numb whatever body part that you need worked on, and we keep you sedated throughout the procedure. But when you wake up, the affected area is numb, yet you wake up very briskly, and then you pretty much can go home within an hour after that, because the sedation wears off very quickly. Those are kind of the three main types that we use.
So we're going to go back to school week one more time. What are the different local programs that are around for somebody to be able to begin practice of?
As all programs, we have become more educated in every field. So way back when I went to school, as I said, I got my bachelor's degree at the University of Akron, and I had to practice for a couple areas. I had to go back to the programs I was interested in attending, apply to them. And back then, they usually had about 40 applicants, and they picked 4 students. You went through a rigorous interview process at the time, and then they compiled all their results and picked your students, and you went back to school for 2 years. And it was just a diploma certificate at the end. So you worked for the hospital, learned at the same time, went to classes at the same time, and did this for 2 years around the clock, nonstop. And then when you graduated, you took a national certification board, and had to, of course, pass that with flying colors, and then you got your license to be a CRNA. Now it's changed a little bit. In the early 90s, particularly in this area, 91 I believe, we developed a program in association with the University of Akron. There's now a master's level nursing specialty, just like midwifery or any of the NP programs. So now you get your BSN in nursing. You have to work again at least a year in the specialized area, either in ICU, emergency room, CCU, the SICU, or one of those critical areas. Then you go back and apply to the University of Akron, have to get accepted into their program, and again take about 2.5 years of classes, and once again take a national board, certification board. Excuse me. And passing that, you are then again licensed to be a nurse anesthetist. But then this time you come out with a master's degree at least, which is great. And now I know we're looking at by, let me say 2021, going to a doctorate level for nurse anesthetists. So it just keeps growing and growing and growing, which is great.
So again, you kind of touched up on it, but the evolution of not just this field, but anesthetics in general is kind of, it's grown a lot since we first discovered it.
It has. Technology has grown a lot. That, it used to be you would sit at the head of the table and you put a mask on your patient's face and you start their intravenous, and every blood pressure you did was by hand, and you had your little earpiece that connected to a monaural stethoscope you placed on their chest. And through this, and you could hear the breath sounds, you could hear them breathe, and you would have to hand ventilate them. Every breath they took, you had to give them. And so then you could hear the breath sounds and their heart sounds through that, and that was plugged into one ear. And only the sickest of sick patients you actually had an EKG monitor on. And many of your anesthetics was all you felt the temporal artery, and you could tell almost by the strength of it about what your blood pressure was, and you could tell their pulse rate with it. And you knew how fast they were breathing because you were doing that for them. And everything went in through their intravenous, and you just control the entire airway with a mask and your hand. And nowadays we have everything. The technology is phenomenal. We have mass spectrometry. We can tell how much inspired agent goes in versus how much comes out, how much they're actually taking up, how high your flows should be, how low they should be. You know, you have second-to-second digital readout of their blood pressure, of their heart rate. We have ventilators on every machine, small portable ventilators. You can ventilate even the sickest of patients with CPAP and BiPAP on these small portable ventilators, which 30 years ago was unheard of. So it's come a long, long way. All of our machines, technology has gotten safer. We have SaO2 monitoring in every room, of course. Drugs have gotten safer, less side effects, shorter half-lives, less allergic reactions to them. The technology has just really come leaps and bounds in the last probably 20 years. But anesthetics nowadays are so much safer than they were 30 years ago. Much.
So as technology progresses, this field gets more advanced.
It does. Much more advanced and yet more difficult. The schooling needs to be longer. There's more to learn. There's more technology to learn. There's more equipment to learn to use. It has gotten much more diverse, and I can understand why we are heading to a doctorate level degree to administer anesthetics. But this is good for the public because it gets safer and safer the further down the road we go.
What problems would you say currently face people who are planning to go into this field?
Probably finances is the number one. That there's and numbers. That there's a large number nowadays. We take a lot more students. We have two programs in the area. One is located at the University of Akron. The other is at the Case Western Reserve in Cleveland. And they interview probably up towards 60 prospective interviewees at a time. And usually I'm taking between 32 and 36, which is a lot of students in each program. And then those students then rotate through all the different facilities that they associate with. But it's a lot of students, so they're grasping at times to get the adequate amount of experience, the numbers of cases they need. Before you can graduate, you have to do so many total cases, and you have to do so many total cases of each type of specialty, so many ENT, so many cardiac, so many obstetrical, so many orthopedic. And so the students are struggling actually sometimes to get the numbers of cases they need because we do have two programs so close in this area. That's one struggle, is just the quantity of students and getting them all rotated and all their requirements met. And then the other is financial, that it's a big expense. By the time they finish their master's level, like any master's level, they're a good $60,000 or more in debt just for the 2 years master's level. It provides a bit of a hardship. Many of the rotations that they're required to do are out of town, and it is their responsibility to find their own housing out of town for 2 and 3 months at a time so they can complete these rotations. Not all, but some are. So it's demanding in that respect. It also is demanding on them that they have to be flexible. Some have to move, and they have to donate all their time to this school of study to get through it and learn what they need to learn. So the family and everything else goes on the back burner for the 2.5 years of the school. It's challenging.
About this field, would you say this field is in high demand for newer people to be employed? Like,
it is. Right now, we're having a high rate of attrition where there's a big group of people retiring. They tend to come in droves, it seems. Now we have a lot retiring. And I think every year our own hospital hires probably at least 6 to 8 new employees, which is a lot. It is. It's very desirable because of the flexibility in hours. It is good pay. It's challenging. It's independent. So it's very desirable, and it is. There's a lot of people going into it, a high influx, and then there's a lot of people leaving it right now in the last 4 or 5 years.
so when you mention there's so many people going into it and there's so many people leaving, would you say that there's still that competition between people for those various spots?
Absolutely, because so many train with us. As I said, we probably have 32 students a year graduate, and most are from this area. And of course, we can't absorb 32 new CRNAs. So there's a lot of competition to be the best of your class, because the best of the class usually gets chosen to stay at that site and work. And then the rest kind of move away and start to look a little further out, which isn't always convenient for their home situation. And some of them actually just pack up their whole house, home, and leave and move to another state to get a job. But we have a lot of schools in this area, actually. And there's one down in Otterbein in Columbus also. So Northeast Ohio, they have a lot of programs. So we've got a lot flooding the market up in this area. So jobs are very competitive.
What would you say is probably the top program for somebody who's considering this field?
As in the best program?
Yeah.
That's a difficult question to answer. Depends on your opinion. That some people think Case Western's best because it has the stigma attached to it. They do have a very fine program. I won't deny that. But if you look at the University of Akron, they have a very fine program. And so much of it is what you put into it. How willing you are to work, how willing you are to look for those extra experiences and get the extra education at work, put the extra hours in. I can't be honest. If you look at statistics, one program over the other does not rate higher on boards or graduate pass boards at a higher success rate. It's pretty even across the state. Just depends really, as I said, on how much you put in the program and your attitude. They both have excellent instructors, and we share a lot of the same clinical settings, so you get a lot of hands-on, which is very similar in both programs. So you really can't say that one's heads or tail above the other.
So you would say students who going into this field, they need to have a high work drive. They need to.
Absolutely. They have to be motivated, self-motivated, and be willing to, dive at 110%. That it is never missed, the fact is never missed the student that says, hey, there's a great case coming in, it's 5 o'clock, I want to stay and do it. And they will. They'll stay over till 8, 9, 10 o'clock at night and do a case. And sometimes they'll get the next day off, but there's no guarantee. If there's good cases the next day, they get right back up the next morning. They're in at 5:30 or 6 in the morning the next morning. The student's responsibility is to come in and prepare the operating room. Hence, the CRNA doesn't have to do that. They have to plan for the cases, write a care plan up, present it to the CRNA they're working with so that they can present their idea of what would be the best anesthetic for that case and how they're going to manage it. They have to see the patient pre-op and know the facts about the patient, what details exist, what they have to avoid, what they can focus on, what they need to, prepare. And so it takes quite a while. So most of our students are there by 5:30 in the morning, every day that they have clinical. And on the off days, they're at the university in classes studying. So it's very demanding and high energy, exhausting.
Now, when somebody gets this job, what would the first few weeks, months be like?
If they have done clinicals in our facility, of course, they will know the situation, they'll know the surgeons, they'll know the physical layout and the policies. So they come in, they usually get about a 2-week orientation. They come in, they get all their credentialing done, all their keys, their locker, etc., and then they get assigned to a CRNA. And they will be doing the actual anesthetics in the room, and the CRNA will just be standing there shadowing them. And if they really are going to do something that probably isn't quite easy smooth, the CRNA will step in and say, don't think I'd be doing that. So they get to shadow them for 2 whole weeks, and then they're pretty much on their own. And we've had real good success with this, that the students, by the time they've worked in this situation and worked in all the environments, they're pretty self-sufficient. They're pretty ready to go. If they come in from outside the hospital, they know nothing. They don't know our policies. They don't know our drugs. They don't know the layout of the land. They usually end up with about a month to shadow someone and be walked around and show them the whole layout of the hospital and meet all the surgeons and work with a few various ones so they know their expectations. So it varies then. So essentially orientation is anywhere from 2 weeks to 4 weeks. And you know what? If you need longer, they get longer. They're very willing to make sure you get well acclimated before they just throw you out there.
Now, does this job vary like on the intensities of the day? Like, can one day you be very, very busy and?
Absolutely. As I said, some days we will do, a dozen cases, short endoscopy cases, a lot of sedations, and they can get routine. Get them in, get them down, get them up, get them out, and it just goes on routine. Other days you'll walk in and do a case, and next thing the trauma team goes off in the ER, and next thing you hear it's coming to your room, and you set your room up, and you have to set up every blood pumping device you have, and get uncross-matched trauma blood up there, and so it can turn from a very casual, low expectation day to just massive. Get them in if you have a decent blood pressure. Give them as little anesthetic as you can to keep them alive, keep them asleep, and then start resuscitating them. Sometimes chest compression, sometimes splitting the chest, sometimes just IV drug therapy. But it can get really, really heated very, very fast. That's kind of the surprise of the position is that you just never know what you're going to be met with. And the same with a routine case. You can start a routine case where you think it's just going to be put down, get to sleep, then start your charting, and get everything under control, and the surgeon begins a procedure, and there's an artery lacerated, there's some catastrophic event, patient arrest. It can turn very, very quickly. So it's either a nightmare or it can be just calm and quiet the whole day. It can change very, very fast.
What would be some equipment that you'd work with on like a daily basis, on a daily work basis? What would be some daily equipment?
Our main piece of equipment, of course, is our anesthetic machine. It is a multitude of smaller machines combined into one. As I said earlier, it's a ventilator. It takes our blood pressures for us. It can control an arterial line for us. It delivers our anesthetic gases. And nowadays it's gotten so easy as you just reach back, turn a dial on, and decide what percent you'd like them on, and you turn it on and it delivers it to them. So that's our main piece. Along with that, then we have a whole multitude. We have an entire cart, like a craftsman cart full of equipment. The first couple of drawers being drugs, that we have every kind of drug that can speed your heart rate up, slow your heart rate down, raise your blood pressure, lower your blood pressure, paralyze you, reverse you, make you salivate, make you not salivate. We have drugs that can essentially do any mechanism to your body that we feel we would need, and all kinds of emergency drugs also. And so after we have that, then the next couple of drawers of stuff is all airway stuff. We use a lot of airway equipment, particularly laryngoscopes, that assists us in placing a breathing tube or endotracheal tube after you go to sleep. We have oral airways we place just to breathe for you while you're asleep if we're just going to control you with a mask. We have something called an LMA, which is a soft airway that we place in your mouth, and we breathe through that for you. There are a multitude of toys of the trade that we can use to assist your ventilation with. So lots and lots of those we use. And then after that, we also have lots of intravenous, different types, IV tubings, all kinds of other types of IV fluid, like colloids as compared to crystalloids that we use a lot on a daily basis. We use blood warmers, a lot of fluid warmers. That the operating room, as we all know, is very, very cold, and it's kept that way because once all the surgeons and everyone is in their scrubs, they're very non-porous, that they don't breathe, so they get very warm. And the lights overhead are, as you know, very bright, and so then the surgeon and all the operative people get very warm, and the last thing you want is someone to start to sweat and or pass out. So the rooms get pretty cold, so it was our job then to keep the patients very warm. So we use a combination of warm IV fluid, so we run your intravenous fluid through a warmer so that as it goes into your body it's warm. And then we also put a warming blanket on you once you're asleep to blow warm air over top of you, and then that keeps your body temperature warm. And then the rest happens when it's really, really cold. So we use warmers however many we need to keep your body temperature where we want it. Keep you nice and toasty while you're in there so you wake up comfortably. So, and that's most of the stuff we use. There's also other adjuncts that we can use. We have specialty scopes to place breathing tubes if we need them. We have, what else do we use? Something called a glide scope. That is a video scope we sometimes use. Pretty much we've got about every toy known to man if we need it. And then there's also resuscitation carts. If it ever comes down to it, we have defibrillators. We have external pacemakers. If someone has a heart problem, we put an external pacemaker on and we can keep the heart beating through that until we can put an internal one in. So there's all kinds of equipment available at all times.
Now, when you watch these TV shows, like these trauma shows about life in the ER and all that, you see these people that walk in and or come in and they have this injury and they're just completely out of it. Do you ever see anything like that in the ER?
Oh, absolutely. First off, we all know those are shows and they are for effect. And you'll see all the people in the operating room without masks on too. and they all look beautiful, and they all have their hair all done. And in reality, the surgical environment is totally sterile, and you have a mask on at all times in there. But when you get called to the emergency room for something, it can be something very minor as a combative person or someone having respiratory trouble, or it can be someone that's totally out cold from a motor vehicle accident, that's had a head trauma, that needs airway assistance, intubated, and an airway maintained. So yeah, we see a lot of them that come in that are just totally out. And from where I work, usually I'm up in the operating room, so they've come to the emergency room, even if they were partly awake and were partially intended. Usually someone put a breathing tube in down there, sedated them so they weren't combative. By the time we get them up to the operating room, frequently they're totally out cold. They have already large resuscitation IV lines in, usually a breathing tube in, and we go from there, put them on the operating room table, and hook them up to our ventilator and go from there. So a lot of times you know them as John Doe. John Doe number one, if it's a multiple accident with lots of victims, we put a tag on, John Doe 1, John Doe 2, John Doe 3, and many times you don't even know their name, who you're working on until a day or two later. We do get a lot of those.
Last question. Do you have any advice for some people who are going into this field?
Personally, I love the field. As I said, I've done it for numerous years. I think it's a great profession. And anyone that was vaguely interested, I would encourage to shadow a CRNA, go around and see what they do, and I would go into it, or encourage anyone to go into it that likes independence, as I said, independence, hard work, the great benefits, and likes to take care of people, because there's nothing more rewarding when you've had a really tough day and you've taken care of someone and you've given your all and it's just all come together beautifully and they wake up very comfortable and they look at you and they just thank you for it. And there's nothing more rewarding than that. It's a very challenging job, but it is a very rewarding, both emotionally and it's a lucrative profession. Again, a very rewarding job. So I would encourage anyone to go into it. It's never boring. And I don't know, a lot of people can say that they've done their job for, I've actually been a nurse in 38 years. I don't know that many people can say that they've been in a profession that long and totally not bored. Never bored. It's always exciting, and I actually still look forward to going into work.
Thank you for your time, Bobby.
You're very welcome. I hope you go into it.